This podcast is hosted by Will Glomsky. Will is an experienced critical care paramedic working on a ground ambulance. This podcast is purely educational, and the opinions reflected are of the hosts only. This show is not intended to supersede any local protocol or training. This podcast covers educational content surrounding emergency medical services. Welcome to the Midnight Medic Podcast.
Welcome to the Midnight Medic Podcast, the podcast where we break down critical pre-hospital topics to keep EMS professionals informed and prepared. I'm Will, and today we're focusing on an essential yet oftentimes underutilized tool in emergency medicine, capnography. Capnography is more than just a fancy waveform on your monitor. It provides real-time insight into ventilation, perfusion, and metabolism. Whether you're confirming airway placement, assessing respiratory status, or monitoring CPR effectiveness, capnography is a game changer in EMS. We'll be discussing what capnography is, how to interpret the waveform, how to recognize abnormal readings, and how to use capnography in different EMS scenarios. So let's break it down. So what exactly is capnography? In simple terms, capnography is the measurement of carbon dioxide, or CO2, in exhaled breath. It is displayed both as a numeric value, end-tidal CO2, or ETCO, and a waveform. This tool allows providers to assess a patient's ventilatory status, circulatory function, and metabolic activity in real time. There are two main types of capnography used in EMS. Mainstream capnography, which is a sensor placed directly in the airway, providing continuous and highly accurate readings. This type is commonly used in the hospital settings or OR due to its precision. And sidestream capnography, which is a sample of exhaled gas drawn into a monitoring device via, say, a nasal cannula or an ET tube adapter. This method is commonly used in pre-hospital setting due to its versatility and ability to monitor both intubated and non-intubated patients. While many providers associate end-tidal CO2 monitoring strictly with intubated patients, it's just as valuable, if not more valuable, for non-intubated patients, helping assess conditions like asthma, COPD, and even sepsis. In fact, using capnography on all respiratory distress patients can provide early warning signs of deterioration long before oxygen levels drop. Understanding the capnography waveform is just as important as the numeric end-tidal CO2 reading. Each breath cycle provides a characteristic waveform that can indicate a patient's respiratory status and provide valuable diagnostic information. So let's break down the four phases of the normal capnogram. Phase 1, the baseline. This represents dead space ventilation with no CO2 present, appearing as the flat part of the waveform. Phase 2, or the ascending limb, this is the beginning of exhalation as CO2-rich gas starts leaving the lungs. The slope should rise steeply in a normal waveform. Phase 3, the alveolar plateau. This plateau represents the alveolar gas being exhaled, giving us the most accurate end-tidal CO2 measurement. A normal plateau is relatively flat, but any abnormalities can indicate airway obstruction or ventilation issues. And finally, phase 4, the descending limb. This marks the start of inhalation, where fresh atmospheric air enters the lungs, causing the CO2 levels to drop back down again. A normal end-tidal CO2 should be anywhere between 35 to 45 millimeters of mercury. But what happens when things really go wrong? Let's take a look at some key capnography patterns and what they tell us. A normal end-tidal CO2 readings and waveforms can provide early warning signs of critical conditions. Here are some examples. Hypoventilation, which is going to result in an elevated end-tidal CO2 greater than 45 millimeters of mercury. A slow respiratory rate or inadequate tidal volume leads to CO2 retention. Common causes include opioid overdose, respiratory failure, or head injuries. Hyperventilation, which results in a low end-tidal CO2 of less than 35 millimeters of mercury. This is seen in anxiety attacks, shock, or sepsis, where rapid breathing blows off too much CO2, leading to hypocapnia. bronchospasm, which is commonly shown as a shark fin waveform. A slanted upslope on the waveform suggests obstructive airway disease, commonly seen in asthma and COPD exacerbations. As the condition worsens, this slope becomes more pronounced. A flat line or a zero end tidal. This could indicate a displaced endotracheal tube, periods of apnea, or malfunction in the monitoring device. Be sure to double check your connections and use that DOPE mnemonic. Sudden end tidal CO2 drops. If it suddenly falls from normal or above normal to near zero, consider cardiac arrest, severe hypotension, or even possibly pulmonary embolisms. Or the curare cleft, which is a notch or dip in the alveolar plateau, also known as phase 3. This is typically seen in mechanically ventilated patients recovering from neuromuscular blockade, things from succinylcholine, rocuronium, vancuronium. This can indicate spontaneous respiratory effort in an intubated patient, often requiring the reassessment of sedation and paralysis. One crucial yet very often overlooked connection in prehospital care is the relationship between end tidal CO2 and lactate levels. Both serve as indicators of perfusion and metabolism, making them valuable tools for assessing shock and overall patient status. End tidal CO2 as a perfusion marker, low end tidal, lower than 25, often suggests poor perfusion, which results from conditions like sepsis, hypovolemia, or cardiogenic shock associated with other poor vital signs. We can use lactate as a metabolic marker. Elevated lactate levels greater than 2 millimoles per liter indicate anaerobic metabolism, meaning tissues aren't receiving enough oxygen due to inadequate perfusion. These end tidals are usually below 25 as well, meaning you have an elevated lactate. When perfusion drops, less CO2 is transported back to the lungs, leading to decreased end tidal CO2. At the same time, decreased oxygen delivery to tissues causes lactic acid buildup, increasing lactate levels. A low end tidal CO2 suggests a high lactate, also suggesting severe shock and poor prognosis if left untreated. Using end tidal in conjunction with lactate when available provides a more comprehensive picture of the patient's overall perfusion status. In prehospital care, low end tidal CO2 should prompt aggressive resuscitation efforts, including fluid resuscitation, vasopressors, and early hospital notification for sepsis or shock management, when combined with other things like Q-SOFA and other poor vitals. So how do we apply capnography in the field? Let's go over some key EMS uses. Confirming and monitoring airway placement. A persistent end tidal CO2 reading confirms successful endotracheal tube placement. No waveform, you may be in the esophagus. And even with alternative airways like supraglottics, Kings, LMAs, and iGels, capnography helps assess ventilation adequacy and detects displacement early. Assessing respiratory distress. Patients with asthma or COPD will show a shark fin waveform indicating bronchoconstriction. Improving waveform shape shows response to treatments like nebulizers. And monitoring CPR effectiveness in predicting ROSC. During cardiac arrest, an end tidal reading above 10 to 15 millimeters of mercury suggests high-quality CPR. And then a sudden rise in end tidal CO2 can indicate the return of spontaneous circulation, otherwise known as ROSC, one of the earliest signs before a pulse is felt. So, capnography isn't just for intubated patients. It's a real-time lifesaver for assessing ventilation, perfusion, and metabolism in EMS. By mastering capnography, you can detect critical conditions earlier, improve your airway management skills, and provide better patient care. Thank you for tuning in to this episode of the Midnight Medic Podcast. If you like it, be sure to share this with your friends. Give us a follow. You can also now search us on Facebook at the Midnight Medic Podcast. We are on Instagram as well. For a link to all of our stuff, go to linktree/Midnight Medic Podcast. I'm Will, and thank you for tuning in.